patients, our clients, whatever we call them to be, we are here to see how we can give the best to them. And it gladdens my heart that we can leave all we have to do to be on this call so that we can learn, rub minds together, and see how we can best serve humanity. I don't take it lightly when it comes to, I see this like something God has handed to our hands to do, the lives of people to, really like touch in this specialty. So thank you all for coming on this call. Let's sit tight and jot down all the necessary things that we know would be of help to our practice even tomorrow as we go to work. And let's put it into practice. Let's not just keep it aside. The person on that is taking this presentation this evening is someone that has this at her fingertips, and at any time you call her, she's able to talk about it so well. So it won't be a boring session. It will be a time of gathering knowledge, and let's not just gather and then just keep it, but let's ensure that we put it into our practices for the best of our patients and our clients, and all that. So it's a good evening, and let's sit tight and get the best out of this presentation. Thank you all, and God bless you for coming on the call. Thank you all.
Thank you very much for that wonderful opening remark. My name is Ali Leila. I'll be a moderator for today's critical care group presentation. I would like to introduce to you the presenter from Yakub Maruf Zuera. He is the Deputy Director.
Hello, Mr. Abdul Karim. Please, can you mute Mr. Abdul Karim? Pharmacist Abdul Karim, can you mute, please?
Let me just go ahead and mute him.
Okay. All right.
All right.
Sorry, please.
So, Naji. All right. As I was saying, I would like to introduce to you Pharmacist Yakub Maruf Zuera. She's the Deputy Director of Pharmacy and Critical Care Pharmacy in Amini Kano Teaching Hospital. She has her BPharm, PharmD, an MBA, and a fellow of the West African College of Clinical Pharmacy. She has her MPharm, and she's also a member of CPAN. Please, I want you to give a warm welcome to Pharmacist Yakub Maruf. If you're ready, ma, the floor is yours.
Good evening, everyone. Thank you very much for your kind introduction, and very happy to be part of the Critical Care Pharmacy Group. And without wasting much time, we're already behind schedule. Let me attempt to share my screen, and let's hope all goes well. Okay. Please confirm to me if you can see the slides.
Yes, we can see it clearly.
Excellent. We're lucky to be. All right.
So you can see.
So thank you very much. So thank you again. So I'm presenting today on fluid therapy as a component of critical care. Sorry, just give me a moment. I'm trying to remove some things on my screen so that I can see clearly. All right. Oh, okay. Sorry, well, I skipped that. Yes, we're presenting today on fluid therapy as a component of critical care. And as we all know, that fluid therapy, by way of introduction, is the administration of sterile solutions, medications, or blood products directly intravenously. And that, as the chair said, a lot of the times we don't consider fluids to be drugs. We consider them to just be fluids. And unfortunately, that is a very wrong perception, and one that is very critical in critical care. Because as you notice that fluids is actually a vital component of fast hug, which is a major pillar in critical care. And you find that approximately 80 or more % of patients are prescribed some form of fluid in hospitals. In fact, sometimes if people go to the hospital and they're on admission and they're not prescribed fluids, they feel as if they are not being treated. So why do we do fluid therapy? We do fluid therapy mainly as a way to maintain adequate tissue perfusion and oxygenation, which is, in essence, if you look at it, a vital component of the ABC in critical care. Remember, ABC is airway, breathing, and circulation. Circulation is hemostasis and hemodynamics. And to achieve that, you have to have tissue perfusion and oxygenation. And in a reverse way, you have to have fluid therapy where required. So it is actually a foundation of the ABC in critical care. And we also do fluid therapy for administration of medications or use in diagnostic reagents, or at times we do it for delivery of nutrients, like in feeding using total parenteral nutrition. Actually, the F in fast hug duplicates for fluid and feeding. This presentation could have been for fluid therapy and feeding, but unfortunately we felt that it was going to be too cumbersome. So maybe we'll have to take feeding on another day. So for fluid therapy, we cannot overemphasize the importance of always remembering and knowing at our fingertips the normal physiological breakdown of fluid compartments in the body, without which one cannot, in essence, practice fluid therapy appropriately and correctly and to the betterment of our patients. So as a short summary here, I've put it up. You'll see the distribution of fluids that are in the body. For example, in a 70 kg man, you have 60% is water, 40% is the non-water part, and out of that water part, 2/3 of it is inside the intracellular fluids, and 1/3 is in the extracellular fluids. This is an area where I find that a lot of people get confused with intracellular, extracellular, intravascular, extravascular. So I think this diagram says it all simply, that there are two major components, the extracellular fluid and the intracellular fluid. And the extracellular fluid is 1/3, while the intracellular is 2/3. Think of it this way. There are more cells in the body than there are. There's so many more cells. So you need a lot of water inside those cells. So you kind of try to remember it like the ICF is where the majority of the water is, and the extracellular is outside those cells. And outside those cells is also separated into two components, where you have the extravascular fluid and the intravascular fluid. Now, apart from the ones in the cells, we have the blood vessels, and that is where the intravascular fluid is. And the remaining extravascular fluid is basically where those cells are swimming. So I think perhaps the next slide will give us a better picture of what we're talking about. And it's important we know the electrolytes that are domained in which component. You find that sodium is basically in the extracellular fluid, as you can see on the diagram there. It's inside the vessels, so it's outside the cells. And the principal component of the ICF, intracellular fluid, inside the cells, and that is responsible for transport. Now, I'm taking a bit of time there because once we have that foundation, we can now move on to knowing that, okay, all the intravenous fluids that we have are categorized into two groups, the colloids and the crystalloids. And the basic marker for the basic separation classification is based on their tonicity, or sometimes by their ionicity. Now, tonicity is simply what we learned basically in secondary school, the gradient issue, where there's an osmotic pressure that separates two gradients, and that they are separated by partially by a membrane. And so now that gradient shift will allow things to move to the left or to the right. And that is where we're able to control, or where the physiological body is able to maintain hemostasis and to equilibrate in fluid situations. So as I said earlier, it's the same thing. The crystalloids are now separated into two, either based on their tonicity or based on ionicity, which is the electrolyte. But we're going to concentrate basically today on the tonicity, where we have three categorizations. They're either hypotonic, isotonic, or hypertonic. Now, I've tried to make this by color coding to help us, to make it easier for us to kind of like keep them by color coding. So we have the hypotonic, the isotonic, which are the green ones, which we really like, which we are, and the hypertonic, which are all hyper up there. And you'll find that the ionic and the non-ionic are actually a redistribution of the tonicity group. So of the isotonics, the most common one, and everybody knows this one, is normal saline. We call it normal. We say it's physiologically isotonic to plasma. It actually is not so, because 1 mole of normal sodium chloride is 58 grams. However, if you dissolve, for you to get normal saline, it's actually 9 grams in 1 liter. However, it's still the most commonly used IV fluids because of that sodium component that we have, which provides us with the major extracellular electrolyte, as I mentioned earlier. And why is this so important? It's because of the ability and the power that sodium has. Remember, basic chemistry, it says wherever sodium goes, water follows. Wherever potassium goes, the group 1 elements, right? Sodium, potassium, wherever they go, water follows. So it follows the same rule. And it is because of this that it is very important in the ability to change hemodynamics for us, to correct electrolyte deficiencies, but the challenge here is that it can also give us metabolic acidosis or edema. It is so common that if it's like what we say, it's like pure water, but it actually is not. It actually is a drug, but we consider it just like sterile water for injection. Now, what are indications for normal saline? Of course, everybody will tell you it is resuscitation of blood volume or correction of BP in emergencies. Sometimes in a group, you can call them hypovolemic shock. Well, not completely, but so to speak. Or we use it in situations like DKAs, rehydrations, kidney fluid challenge, which is a very common thing in the ICU, irrigation of body compartments, or use it for administering drugs, where we put other injections into normal saline and we run them over a period of time, or we just simply use it to keep our lines patent so that they do not tissue up. But we must be cautious because that sodium, remember, it's going to pull water into the vascular system, and so can predispose us to hypertension, preeclampsia, or it can cause dehydration where we have severe hypokalemia. And when we infuse large volumes.
Hello, Farm.
Yeah.
Yeah. Can you be a little bit louder? It's we're hearing you faintly. So people are already putting it on the chat. Yes, I think if you can be a little bit louder, we will hear you better. Thank you.
Okay, I'll try. Is this better?
Yes, I think it's a lot better now.
Okay. All right. So so that's why it is most advisable that we use the balanced crystalloids, which are closer to plasma and are renally protected. Now, the second isotonic one is we have Ringer's lactate. Actually, Ringer's is actually more superior to normal saline because it is the most physiological fluid, as the electrolytes are very similar to plasma. It's actually the fluid of choice in ICU. However, you find that in actual practice, we are just much more comfortable using normal saline rather than Ringer's saline. But everywhere in the world, you find the Ringer's saline, Ringer's lactate is the fluid of choice in the ICU. And why? Because it contains sodium lactate in addition to the sodium chloride, calcium and potassium. However, at the same time, there are situations where this addition is particularly where we have challenge that we do not wish to have any more potassium, like where we have hyperkalemia in a patient, regardless that it's the fluid of choice, but because of that, we cannot use it. And I think that is what predisposes most of our ICUs as to leaning towards more towards normal saline. But because of this, it also has this component of sodium, which gives us the same volume expansion that we want. And the other advantage is that the sodium now metabolizes to bicarbonate, which where we have metabolic acidosis, which is a very common thing in the ICU, we don't have any problem because the bicarbonate will take care of that. So indications for Ringer's lactate is hypovolemia, burns. It's actually the fluid of choice in pediatric diarrhea. It's actually the fluid of choice in postpartum hemorrhage. That's why you find a lot of use of it in O&G, in labor, postnatal, because of this particular property that it has. And it's actually the best maintenance fluid in surgeries too. However, as good as that is, we also have the challenges of that it has drug interactions like with amphotericin B, ampicillin, and doxycycline, and in situations of liver disease or Addison's disease, or where we have to use simultaneously with blood, because the calcium in the Ringer's lactate now binds to the blood, and so wherever you are going to has to be used, it cannot be more than a ratio of 1 to 2. That is a ratio of 50% Ringer's to the 50% of RBCs. So it's just these few things that make most people not want to use Ringer's, and they prefer to, let's just go to normal saline. I don't want to have to remember all these challenges, but it actually is the best fluid of choice in the ICU. The other isotonic group is the Diros solution, both full strength and half strength. Very similar to Ringer's. The only difference is that it has a higher concentration of potassium. So where you have a situation where you do not have any of those contraindications and you are doing potassium correction, you can actually use this, and it saves you having to go to add KCl into your fluids to do hypokalemic corrections, which is a very common situation. And remember, the presence of potassium takes care of action potential, affects insulin release, and all of that. And so Diros solution is a good option to have, especially where you have challenges and you have to substitute. And the half strength and the full strength are exactly the same. The only difference is that half is actually half and full is actually full, meaning that full is double the half. And it is indicated for blood loss, fluid loss, and as I've said earlier, low potassium levels. Now, the other group is the Plasma-Lyte. We don't really have the Plasma-Lyte. I don't know if I stand to be corrected. Maybe other facilities or other ICUs are using Plasma-Lyte, but in my facility, we don't have Plasma-Lyte. But I felt it was important that you know that it does exist. And it is just the same as our full strength and our Ringer's, only that it has a composition that is just so similar to Ringer's actually. And it comes in different forms and different numbers. Like this one, you see it's Plasma-Lyte 148. So it has its own composition. And then we have the other Plasma-Lyte E that is for pediatrics, kind of like the same we have the pediatric saline and the dextrose saline. But that is basically just the difference between the two of them. So those four are the isotonics. Those are the normals. Those are the closest physiological fluids that we have. Then we have the hypotonics. Now, who are the hypotonics? The hypotonics by color coding are the yellow-orange, 4.3 and 1.8% saline and dextrose in water. If you notice on this table, the only difference here, the major difference, so to speak, rather, is the absence the presence rather of dextrose. So what is the effect of dextrose? Because otherwise they would be the same like normal saline. Now, the only effect of dextrose that we have to keep in mind is that, of course, surely it increases blood glucose levels. It will, because of that, give us potassium sparing effects, and it will increase osmolality because it will now result in volume effect. Now, the dextrose will move into the cells, and because of the molecular weight of the dextrose, it will create now a water gradient, meaning that there will be a shift of water into the cells. That is why sometimes when you observe, when patients are given 5% dextrose water, within a few hours, you see them looking really chubby, looking really fresh and all of that, simply because of particular effect. But non-ionic solutions, that is the 5% and the 5%, they do not restrict themselves to the ICF. They actually expand all components of the ECF, but usually at a cost of. So the limitations for the 5% dextrose water is we cannot use it in hypovolemic shock because it cannot expand the IV volume, intravascular volume for us. And if you infuse too fast, then because of that same dextrose effect, now you're going to have diuresis, and you think your patient is well hydrated. Well, he isn't actually. You find he's actually dehydrated because of the sugar content, the dextrose content. And it will aggravate our cerebral edema, increase our ICP because it is now drawing more water inwards, and worsen our ischemic strokes, and also cause electrolyte derangements because of the huge shift in electrolytes. But the 4.3 dextrose in saline is indicated for children, and it is actually the best for rapid correction of hypoglycemia in pediatrics. And where you have to do a treatment of insulin, remember that potassium affects insulin production. Lower levels of potassium will produce lesser insulin, and lesser insulin leads to hyperglycemia, a pseudo hyperglycemia, so to speak. And so that is an effect that one needs to be always cautious of. So the other group is the hypertonic fluids. We have done the normal, we have done the hypo. Now these are the hyper. And so who are the hypers? The hypers are in the blue. Normal saline 3% to 25%, the mannitols, and the dextrose. But the dextrose 10%, because the 5% is hypo, it is less in tonicity in our cells, but the hyper is going to be is 10, 25, and 50%. Now, what do? The hypertonic saline is simply a much higher gradient that shifts the water from the intracellular fluids into the extracellular fluids in a much faster and more intense manner than normal saline does. So when we want rapid plasma volume expansion, or we want reduction in elevated ICP significantly, because they are even superior to mannitol, or we want to correct hypoosmolar hyponatremia. Now, this is a very common use of the hypertonic salines, especially the 3% or the 5%, even in children. In fact, they are most at risk, and usually the 3% is mostly used for pediatrics to do that. And the other hyperosmolar fluids are the mannitols, the 10% and the 20%, which we all know. But basically, their characteristics are, we know that they are actually osmotic diuretics, metabolically inert, come across the BBB, and are our fluids of choice in reducing ICP. But recently, the practice is that you'll find that majority of ICP reductions in the ICU are done with 20%, or rather in all A&Es. And this is simply because of the volume of fluid. If you need to reduce ICP using 250 mils of 20%. If you're using 10%, that means you have to use 500 mils. And that kind of like adds another 250 mils to the work we have to do to reduce ICP. And the complications are usually rebound edema. That's why they're just used for a short time. And the limitations generally of the osmolar fluids are hypotension, of course, pulmonary congestion and edema, which actually makes sense because we are not pulling in too much fluid, and anuria due to renal disease in situations whereby we have the renal system is compromised. Now, this is a table. I like to look at it regularly. After a while, just have it in your head, and anytime you have to use this, just refer to it. You'll see the similarities and the differences between the different kinds of IV fluids. The ones represented here are only the isotonics. The hypertonics are not represented here, neither are so just bear that in mind. But this is a very nice table to refer to when you have to make decisions. You can actually keep a printout of it and then just in your file in the ICU and just make a reference to it. So these are all the crystalloids. So who are the colloids? Remember, there are two categories of IV fluids, the colloids and the crystalloids. So the crystalloids are glues. And why do they call them glue? Because they are suspended, large molecular with sticky suspensions. But it is simple, and it's particularly because of this property that they have, that they're able to create, higher osmotic oncotic pressures, and they're actually plasma potents. A majority of the colloids that are in the plasma, physiological ones, like albumin is the major physiological colloid. We have other synthetic colloids that are developed and used, or blood products that are used, but they are sometimes majority of the main challenge we have with them is the issue of reactions that patients have to them, and so it makes it difficult to use all of them as we would want to. But they significantly expand plasma volume, and they actually have long T-halves, which is really useful. So examples of colloids, we have the naturals and the artificials. The naturals, we all know this one, fresh frozen plasma that is used to centrifuge from blood that is donated or collected, the albumin 5, 20, 25, everybody knows those ones, and the plasma proteins that are physiological. And the artificial ones are the dextrans, the gelatins, and the hydroxyethyl starch. So this table now just shows us, gives us an idea when you look at it of the different kinds of colloids. If you look to the fluid side, you see albumin 5, 25, and then the other group, the dextrans and the heterostache. Now, if you look at the oncotic pressure that they create, you see 5% is just 20 millimeters of mercury, 25% is 70. And look at the corresponding plasma volume expansions. So that gives us the choice that how much plasma volume expansion do we want, and for what duration of time do we want. Then it helps us to choose which is our best colloid to use. And remember that colloids are able to, as much as 3 times, be more effective in expanding the plasma volume than crystalloid fluids. So in situations of significant plasma volume loss or need for plasma expansion in a very, very short time, and at the same time maintaining a long duration of effect, colloids are our choice, not crystalloids. So comparatively, when you look at crystalloids and colloids, it's important to know their characteristics, because this is what will help you to make the right decisions and to make the right calls and to be able to identify what contribution you can make in the ICU. As stated here, you see the crystalloids, they are aqueous solutions, low molecular weights, they are easily passed through the membranes and can give us expansions. You can see their T-half is 20-30 minutes, not much oncotic pressure effect. We have tissue edema as a side effect. We don't have reactions. They are inexpensive and available, which is very important in the Nigeria of today. Very available and well tolerated. For the colloids, our major advantage is that they maintain colloidal oncotic pressure. They have good capillary perfusion. We don't have any problem with tissue edema. However, they're expensive, more chances of anaphylactic reactions, which is very costly if it happens, and they are not so readily available and not so well tolerated by patients. So it is what these are the characteristics that help us to choose which one do we choose and which one do we use. So it's a general guide to therapy. we should always at the back of our minds remember that the first thing is we determine what is the cause of fluid loss. What type of fluid loss? Is it blood? Is it fluid? Is it body water? And what is the volume? Is it minimal? Is it significant? Is it moderate? Not. And then we now make the decision to choose the appropriate type of fluid that matches what we have lost, and how do we replace it back. And then while we do that, we must monitor all our parameters closely, and we must adjust. Fluid replacement, fluid therapy is dynamic. It is not just something you just give and walk away. No, it doesn't. You have to keep monitoring, and we have to avoid overhydration. I'm sorry, I think there's a type error there. All right. So now that we know we need fluid balances, we need to understand what is the normal fluid balance in a normal physiological body. We have fluids on the blue. On this side, you see we get water from our food, metabolic water, or whatever we intake. Just notice that this man is standing on a scale. To the left is, or rather to my left is intake, and to the right is loss. So here we have to maintain a balance. And our balance end is the fecal loss, the sweats, the urine on that side. So averagely, if you look at the table by the side, this is what we have. We take oral fluids, we take water in our foods, and so on and so on. And then we make outputs, insensible loss, stools, and all of that. Ideally, they should balance for us to be EU hydrated. But how many types of balances can we have? We can have a negative balance, whereby we create a situation where we want a fluid deficit, whereby our fluid loss is greater than the gain. Sometimes we create it intentionally in patients. Or we want a positive balance, which means that we want what we put in to be more than what is lost. Or we want a zero balance, whereby we look at exactly what is lost, and we replace exactly that back. So it's important to know these different kinds of balances, because there's always a role for them in fluid therapy. Where do you want your patient to be? A negative balance, a positive balance, or a zero balance? So how do we know what we need? So this is a way of calculating our daily fluid requirement. Please note that this is a requirement, because going on, we're going to go to maintenance. First, we need to know, what do we require? So for example, a normal adult requires whatever is his urine output plus the insensible loss. So minimally, it is expected that for a normal healthy person, urine production is 0.5 to 1.5 mils per kg per hour. So if you calculate that, the minimum should be like 840 mils in a day. Plus the insensible losses we calculated in the other slide at 700. So the minimum requirement is like 1,540 mils in a day. However, the maximum ceiling for acceptable urine output is 1.5 mils per kg per hour. So if you calculate that, it gives you about 2,520. And add the insensible losses. Remember, in our own climate, you have to factor in whether it's cold, whether it is hot, whether you're in the south, where there's humidity, whether you're in the north. So these insensible losses can change. This is just kind of like a guide. And so we would expect that anything above 3,200 mils per day is a normal, it's enough of a requirement for that adult. Another way of calculating the daily fluid requirement is to do it by body weight, not urine output and the losses. So we take it that, so if a person is a 70 kg person, so we calculate that for the first 10 kg that he has, he needs 100 mils per kg per day. That makes it 10 times 100, which is 1,000. And then he now has a balance of 60 kg for us to balance. So out of that 60 kg, for the next 10 kg, which is 11 to 20 kg, now we want to give him 50 mils per kg per day, which means 50 times 10, which is 500. So if you add that 500 to the previous 1,000, he has 1,500 mils. That has accounted for 20 kg of his body weight. So we have an outstanding 50 kg now to fill up a fluid requirement. And for that, anything above that 20 kg is a 1 mil per, it's a 20 mils per kg for anything above that first 20. So that means it's 20 times that balance 50, which is another 1,000 mils. And you put everything together, it gives you 2,500 mils for the day. So I ask everyone while we're doing this presentation to please calculate your daily fluid requirement in mils, and maybe we'll share it on the chat before we get to the end of the presentation. So all these ones, either by urine or either by weight, is our requirement. Now, after we have gotten our requirements, then we have to maintain that hydration level and we have to maintain that fluid level. And how do we maintain it? Remember, loss is continually ongoing. So how do we maintain? Usually we maintain, the simplest way is using the Holliday-Sagar 4-to-1 rule. And the 4-to-1 rule is as simple as the previous one. It's the same thing. For the first 10 kg, 4 mils per kg per hour. For the second 10 kg, that is 10 to 20 kg, 2 mils per kg per hour. That's why it's called the 4-2. And anything above that is 1 mil per kg per hour. So the advantage of the Holliday-Sagar rule is that we can use it for adults, we can use it for children. It applies the same way. It doesn't change. It doesn't matter. So once you look at someone and he is above 20 kg, you don't even have to go backwards and start calculating. You just look at him and you say, okay, we already have 1,000 mils on ground. So we just need to add on top of that. So you can see the example there for 5 kg infant and for 15 kg child, what is our maintenance fluid. This is the same thing, just in a different format, but this is the 40 plus weight plus 40. It's the same thing actually. If you study it, it will still just take your weight and add 40 and we're there, because the first 4 is the 4 mil per kg and then the 2, and that gives you the 60 and then 1 mil for the next kg. So it's always give 60 mil per hour for the first 20 kg and then you add whatever is left for the maintenance. Now, definitely we have situations where we have to do fluid adjustments for situations that present, whether it's a fever, because remember what we calculated was requirement, and then we maintain, and then we're all fine, and then we have a fever. And so that is now going to increase the rate of our sweating and fluid loss, or burns, or surgical drains, or sweating, or whatever. So we have to now calculate adjustments for fluid requirement. However, that's a whole huge issue on a huge chapter on its own, and I felt perhaps we can do situation. So after we have requirement, maintenance, and adjustments, then we have to do monitoring of fluid therapy. And in monitoring of fluid therapy, which is critical so that we do not overhydrate or underhydrate, we have to monitor the clinical signs of overhydration, hemodynamics, serum electrolytes, and urine output. Of all the monitoring of parameters of fluid therapy, the easiest one is urine color. It requires nothing, just visuality. For ourselves, for anybody, for patients, you just look at it. You can see the color code in there. The color just guides you. Once you see that, you know there is a hydration issue, whether it is overhydrated or there is severe dehydration. And you can see the average urine output that we expect, which usually corresponds to the color of the urine that we obtain. And fluid monitoring chart is very crucial and critical, and you just need to put in the intakes. You can see the different categories of intakes, and you can also see the different categories of outputs there. And once you have all those calculated, it's very simple there. You look at it and it gives you an answer to where it is that your patient stands. You usually find this chart in the nursing chart, so it's very accessible. So now, what are our complications for fluid therapy? As much as we want fluid therapy, as much as we like it, and as much as it helps us, but there is a border for everything. And our major complications are two: hypervolemia and electrolyte imbalance by dilution. So what does it mean when we have overhydration, fluid volume excess? We have too much fluid going in, but it is not, the input-output chart is not balanced as in the fluid monitoring chart. So what are the effects of this? You see that too much fluid, causes pulmonary congestion, which is fluids in the lungs, and this can lead to this can lead to respiratory failure and put us in another situation that we don't know which to be. Neurological changes, cardiovascular and respiratory are the most detrimental of all of this in overhydration, because wherever we have a situation where our patients are having compromised cardiac systems, and which is usually the case in ICUs or respiratory situations, then we just give them a chance for the worse. And edema collections and overstressing the kidneys, and in compromised kidneys, we just make things worse. So how do we manage overhydration? The best thing is prevention. Prevention is key, and what is the best way to prevent is to monitor, constantly check and constantly review. Fluid restriction, we already have the situation of overhydration. Well, then number one is if we have not prevented it, then we restrict it. We restrict the fluid. You'll find this is where situations of negative balance come into play, where you see the patient is now placed strictly on negative fluid balance. We give very little and then we expect them to come out. Sodium restriction, because of the effect of sodium, we have to sometimes use diuretics, the loop diuretics, especially like furosemide, and in worse situations, we just go for dialysis to remove the fluid. As a caution, either way, hypovolemia or hypervolemia are harmful. If we hydrate, resuscitate, we have edema, ARDS, and AKI. If we we have hypoxia, organ dysfunction, and organ failure. And it is also very important that we avoid blind fluid loading. And this means that situations whereby we do not have the markers, we do not have the chart, we do not have anything, and we just decide, and we do not calculate, and we do not know the weight, and we do not know the urine output, and we simply decide, okay, you know what, let's just rush in 1 liter, and maybe then later on we will assess. That's very dangerous and should not be done. So in resuscitation, in fluid therapy, the cardinal rule is the 5 hours of fluid therapy. And as it is there placed on the chart, you see that we have resuscitation where it is needed, but which is a very common thing in the ICU. Routine maintenance is what we have discussed. And in routine maintenance, you have either you go for replacement, meaning that you add to the maintenance, or you have redistribution, meaning you're adjusting your maintenance. And then you reassess, and then you keep going around that same circle again, unless you have to go to resuscitation. But if there's no resuscitation, the routine maintenance, the redistribution, the reassessment, the replacement, you just keep going around and around them all the time. And so for resuscitation, we have 4 phases of fluid therapy for resuscitation. And the resuscitation is crucial in restoring hemodynamics and organ perfusion and maintenance of circulation, and as is important as we know it is. So for the first phase is the rescue phase. It's called the Rose model. It's the rescue phase where we have resuscitation, where we restore perfusion. Usually, look at the graph there, you will see there's an escalation. It's almost a 45-degree line. That means that the time versus the volume you are putting the volume is much higher than the time, because you are trying to do restoration. Optimization is where you have achieved some level of stability, and now you are optimizing perfusion. And stabilization is similar to optimization, but at that point you are quite comfortable that everything has stabilized now. And then the de-escalation phase is where now you have to minimize fluids and allow usually to do diuresis or to allow the fluids to drain out after resuscitation and restabilization. Now, this chart, if you look at it and go through it, because of time, you will see the principles, the goals of what we want to do in rescuing. We want it's a life-saving situation for resuscitation. We want to collect, usually in shock. We have to do it in minutes. It's usually a severe shock. And we have to give boluses in situations like septic shock or major traumas like accidents, bleeding, hemorrhages and stuff like that. For optimization, we're rescuing the organs. For stabilization, we're supporting the organs to do. And you'll see that in optimization, we are doing optimal tissue perfusion, and we titrate the fluids for conservative management for fluid challenges. But in stabilization, you see that it takes a while, and we usually go for 0 or negative balance, and we do minimal maintenance. And for de-escalation stage, we have already gotten to where we want to be, and it takes us a long time to do the recovery phase. So this is a simple guide for fluid resuscitation, and the key thing to keep in mind here is that you have to choose your optimal choice of fluid. Infuse 30 ml per kg start of crystalloids for initial resuscitation. This is cardinal, 30 ml per kg start. And where it is blood loss, the conversion factor is for every 1 ml of blood you lose, you replace 1 ml of colloid. But if you're replacing crystalloid, it's 3 ml. And that's why you'll see the chart there that says colloids 1000 ml. You put it in, it goes through, it takes the entire 1000 ml into the ECF. But for others, normal saline and dextrose, the hypo and the hyper, the hypo and the iso, you find that now they redistribute into the other compartments. So continuation of guide, if it's not satisfactory, you keep repeating, and then you maintain a strict fluid input-output chart, and then you continue dosing further fluids based on the measures of your expected hemodynamic response. So in all of this, what is the role of the critical care pharmacist? And summarily, our role in the ICU is to guide the fluid selection and compatibility. And this we can only do if we have a good understanding of our fluids and the guidelines and the situations that they present, and how to manipulate the fluids and the body compartments to get what we want. And to monitor drug fluid interactions and electrolyte balances. Remember, we also have to remember that the interactions between drugs and fluids, like in the situation of Ringer's. And to promote rational and safe fluid use, evaluate electrolyte and osmotic balances, review compatibility and osmolarity, and to adjust drug dosing for volume shifts, because certain drugs will on their own have, like the diuretics will, if you're using them for a separate reason apart from fluid therapy, or what I mean by fluid therapy, meaning that you are not using them to correct overhydration. You are using them, for example, to just naturally, for like a CHF patient, and you're just trying to reduce fluids. And so you have to look at that. And then it's important that we lead ICU fluid stewardship programs. And it's kind of like not new, the fluid stewardship programs in the ICU, but as a reminder, it is actually a stewardship that reminds us that IV fluids are drugs, and the stewardship focuses on us reassessing the indication and the volume of fluids that are given, and for us to advise change of fluid where appropriate. This is where we need to know all the characteristics of our fluids, and to document fluid balances, monitoring effectively, and we also have to comply with our unit-based or our institutional-based protocols. So our key takeaways today is that, one, fluid therapy, fluids are actually critical drugs, as much as they are not considered so, but they are. And the goal of fluid therapy is to restore perfusion and avoid overloads. And we will always prefer balanced crystalloids. amongst all the fleets. And we always have to do continuous reassessments, and the pharmacist shall ensure safe use of fleets. So tell me, while we discuss, how is fluid therapy handled in your ICU? And perhaps what are the common barriers to pharmacists input in the ICU? If there are any, let us share. Thank you very much.
Yeah,
Thank you very much for that beautiful presentation, self-explanatory. You did a good job analyzing, breaking down everything for us. And the title again is Fluid Therapy as a Component of Critical Care. Presenter took us through the ECF and the ICF, the different crystalloids and colloids that we have. We saw complications of fluid therapy and how to manage overhydration, resuscitation, and most importantly, the roles of the clinical pharmacist in critical care, which include lead ICU fluid stewardship programs, promote rational and safe fluid use, which cannot be overemphasized, monitor drug fluid interaction. Thank you once again for that beautiful presentation. So the floor is open for, for anyone who have questions. I think somebody just mentioned, I think we have a few issue of low quality, poor audio. Poor audio. A number of people have complained about the poor audio, but I think the audio will be available, and also the I believe the slides will also be available so that we can go through it again. Thank you very much. So the floor is now open for any questions, contributions, and comments.
Sorry,
Yes,
can I come in
hello.
briefly? Can I come in briefly? Sorry, just a quick
Yes.
one. Yes, I want to just briefly appreciate Dr. Zwera for such a brilliant presentation, and also to quickly acknowledge people that have been on the platform. They came in subtly like a thief in the night. But they're here with us, and I want to acknowledge their presence before we now go into giving the platform for people to speak. I want to appreciate the pioneer of the CPAN, Dr. Madu. Dr. Madu is on this call. Dr. Madu, we thank you for taking out time to be on this call. We appreciate your time. And are you there? Just a brief word to us. Hi, or something. Just a brief word to us before I move on, Dr. Madu, if you're there.
Good evening, everyone. Good evening, our dear presenter, moderator, and all members of this specialty group. I didn't want my name to be mentioned. I was just hiding. I changed my name to Dr. JM. All right. So thank you so much for recognizing my presence. And I must tell you, I'm learning a lot this night. God bless us all as we continue to learn what will help us to advance patient care in life. God bless all.
Thank you. I also want to recognize the presence of the immediate coordinator of the critical care specialty, Dr. Nwafu. She's also on this call with us. Ma, just a little word of encouragement, ma'am. Hello, Dr. Nwafu, are you there?
I'm here.
Okay, ma'am.
Okay. What is to make comment? Hello?
Yes, ma'am, we can hear you.
I was thrown out 2 minutes ago. You want me to make comment? Okay,
Yes.
okay. Good evening, everyone. I'm very, very glad to listen to this wonderful presentation tonight. I just want to start by thanking our dear new desk officer one, Pharmacist Moese Babalora. Thank you so much for this great work you're doing now to really bring up our dear specialty group, critical pharmacy. I want to thank the presenter. Wow, I'm not surprised, my dear. Thank you so much for this wonderful presentation and to the moderator. I learned a lot, even though I've been working in the dental chain for over 13 years. But I got new information that will help me to take care of our patients. Thank you so much. The new trending word now is fluid stewardship. So in ICU, we have different types of stewardship: antibiotic stewardship, anticoagulation stewardship, fluid stewardship. Just last week, uh, anesthesia physicians, the theme of their conference was on this fluid stewardship. So it's very, very important that we pharmacists understand it, and so that we can really play our role very well. As she made us to understand that you must have to help to determine the right fluid at the right time, and also even to know about the compatibilities. They are all the roles of pharmacy. I have just little questions to ask. In my own center, sometimes we run short of hypertonic saline, okay, and we always make use of table salt. So I don't know whether it's available in other institutions. That's what we do anytime we run short of hypertonic saline. So I really want people to throw more light to what is obtainable in their own facility. So sometimes hypertonic saline may be scarce to get it at that point in time. Okay, so basically, I love what happened tonight and I really added to what of my knowledge. Thank you so much.
And so I think maybe the questions will come together when other people ask them, so she can give the answers at once. So Dr. Lua
Yes, good
Timilehi,
evening.
thank you for coming.
Hello.
Yeah, thank you for coming
Hello.
on the call too. Yeah, yes. And
Hello.
yes, because of time, I may not be able to call everyone, but then I appreciate everyone. Pharmacist Josephine Bidiok,
Thank
thank you.
you.
Yeah. All right.
Hello.
Okay, please. Yes, we can hear you. Please go ahead.
Okay. I
Thank
just
you for
want to.
recognizing me. I enjoyed the presentation. Well done.
Thank you. There are a number of other people, plenty, but then because of time, I can't acknowledge everyone. Please, I appreciate everyone for coming on this call.
It's a
All
great
right.
presentation. Hello. The presentation was great, and I want to ask, how do you monitor fluid intake? Is there an algorithm for it where the pharmacists, enter the ward and can look at the chart and say, okay, this is the level of infusion that the patient needs? Is there an algorithm for it? Hello. So,
Yes, please let people ask questions. If you have any question, please go ahead. Let her get all the questions together and answer them at once so that we can save time.
Hello, good evening all.
okay.
Good evening, sir.
Yes, thank you for the beautiful presentation. I have questions as follows. My first question is regarding fluid stewardship. You find out that all patients in quotes that are admitted in the hospital they are normally placed on flute. Is it the right practice or there are issues around it? Because most of the time, including patients that can take food orally or any other thing orally, you'll see that they are always placed on flute. Even though some patients, will, if you observe them critically, you'll find out that they don't actually need the flute. Then the next question is concerning the flute monitoring chart, the input and the output. I want to ask, I want to believe the output that is being measured is for the urine, as in the input output, the output component that is being measured is the urine output. So my question here is that what about the other routes of fluids that leave the body, example, through the sweat, through the saliva, and other means? Are they negligible enough that it's only the urine that is being put into consideration? Then the next question is concerning the choice of fluids and contraindication. You find out that patients that are diabetic, you don't give them fluids that contain dextrose. Those that are hypertensive, you don't give them normal saline. So my question around this is that, is there a rule of thumb concerning the use of fluids in maybe either diabetic or hypertensive patients, or it's their condition? Maybe for hypertensive patient, it's the blood pressure, measurement value or reading at the time when the fluid is administered that will determine whether a normal saline can be given or not, while for diabetic patients, it's the blood glucose level. So I need more clarification on that. Then the last but not the least is fluid stability. You find out that most often in lower temperatures, fluids like mannitol, it's used to crystallize. So in such situation, how do you dissolve it to have a clear fluid? If it's possible to dissolve it to have a clear fluid, is it safe for use? As in after it have maybe precipitate and form crystal, when you dissolve it into clear solution, is it safe for it to be used clinically? Thank you.
If it's crystal, you don't use now.
Over.
Over and out.
Oh, sorry. Thank you for that question. Over to you, our presenter, Ma.
Yes, thank you very much. Thank you very much for. I thought I had gone over and out. Somebody mentioned that over and out, so I thought I had logged out. And yes, so Dr. Marin, very nice to hear from you, and thank you for joining the call. But I'm sorry, I didn't get your question fully. I got you mentioned that the issue of availability of hypertonic saline, and that you use something, and then I didn't get the rest of it. Would you mind repeating that, please?
Use of table salt.
Use
When
of
there is
table
no-
salt.
Yes,
Oh,
when there
okay,
is-
okay. Use of table salt in the absence. Yes. Necessity is the mother of invention, so to speak. And it is true that you find that where there is need for urgent correction of hyponatremia, and the availability of the hypertonic salines is not there, especially usually the 3%, which is the closest one that we can correct using table salt, especially in children. You find that rather than the problem of maintaining the hyponatremia and having a system collapse, and in the absence either by availability or by cost, because sometimes people can't afford it and our healthcare is not having adequate coverage, the use of the table salt, actually, we also use it in our facility in situations where we cannot and have an emergency. So they add table salt into the diet of the patient to see that we are able to have more sodium being absorbed inside the system. Yes, so it is not a peculiar practice to your facility. Thank you. The other question about monitoring fluid intake, whether there's an algorithm to it or not. I don't know if I can share my slide again. The monitoring of fluids. Can I, moderator, can I share my slides again? Is it possible?
Absolutely. I think you still have, yes, you're still a co-host, so of course, you can go ahead and share.
Okay, let's hope. Okay, excellent. Right. So about the fluid, monitoring the fluid intake. I assume you're talking about hospitalized patients. Now, when you're monitoring fluid intakes, look at this chart, this fluid monitoring chart. It is expected that, remember the assessment, maybe I should go back to assessment. You see the assessment for fluid therapy, you see clinical signs of overhydration or underhydration, hemodynamic monitoring, serum electrolytes, urine output. These are all supporting markers that help us to monitor the fluid status of the patient. And it is based on that the decision to do fluid therapy, which fluid, how much, and so on is made. And this chart is used now to take that into consideration. That's why I presented all the different kind of balances that we have. Now, if you look at it, somebody asked, I think I will use the opportunity to answer two questions at once. If you look at it now under intake and you see input and output, now or under intake, you will see oral or intravenous. And you see what is the fluid type, what is the volume, and what is the accumulated total over time. You can see time here. And if it is an intravenous source, you can see it's the fluid type and the volume and the accumulated totals. And whether it is a blood product, the volume and the accumulated total. So when you put all of this together, and then you come to the outputs, and the outputs here tell you that whether it is the nasogastric tube, what do you have, the accumulated total, whether it is urine. Now, the other ones that were being asked about sweat and so on, they are considered insensible loss, usually estimated because you cannot measure the amount specific, to exactly of how much sweat a patient has had. But sometimes you can see that if he is sweating profusely, you can estimate that, okay, what I'm going to give, what I need to adjust for this patient is actually more than the other patient that is not sweating so much, and taking body size and surface area into consideration. So that is kind of like an estimation thing. But if you come down to the bottom, you will see that the summaries are here where you have total input, oral and IV, total output, excluding insensible loss, fluid balance, total blood in, total blood out, and what is our total balance. So I hope this answers that question. Now, I think that is the monitoring chart too. And then the choice of fluids regarding whether the patient is hypertensive or diabetic, and whether there's a cardinal rule that says we cannot give them. No, it is just a caution, because when you have a hypertensive patient, he has to be a known hypertensive patient for you to even start having that consideration if he presents in an emergency situation. But even if you know he's a hypertensive patient, the decision is always clinical as to, okay, what is our situation? Because we can actually give normal saline to a hypertensive patient, and we actually can do it under just the same way we do diuresis under furosemide loop diuretic cover, even though we have a lot of fluids, but we still give fluids, but then we drain it out. So in the same way, you can actually have a hypertensive patient that you put on antihypertensives, either orally or parenterally, usually in the ICU, and at the same time we use our normal saline, because we need that we need that extravascular perfusion, that volume to accumulate, and so that we can have good perfusion. Besides, usually if you have hypovolemia, it is hard for you to have a raised BP, even though it is not that it is impossible, but it is so much easier for us to control the BP with agents that we can use to crash the BP down, but still do our hydration. because hydration is actually more important than the BP, because the BP, remember, the strokes volume and the formulas for calculation of cardiac output and so on are dependent on fluid. And without that fluid, we're going to have that challenge. For diabetic patients, it's actually more applicable to diabetic patients because of issues of hyperglycemia. But even those ones, regardless, you find that you can always use a dextrose-containing fluid if you need it, and at the same time, you just adjust your insulin to cover that period. I don't know. The fluid stewardship, is it right to provide is it right to practice to always place I'm sorry, I didn't get that much. Moderator, can you help out?
Yes, so sorry, what I was asking is that in most of the time you'll find out that patients that are on admission in hospital.
Oh, yes, I get it. Are always placed on fluids. Yes. Now, that is actually not our calling. It is the clinician's calling. They've assessed and they feel that this patient needs to be in fluid. Now, this is where our fluid stewardship comes into play, because when they make the decisions that we need to place this patient on a fluid, and we know the markers and what it is that we need to assess in overhydration, dehydration, and euhydration, that means we are better able to make interventions and better able to discuss, from a perspective of stewardship, that, okay, why are we given the fluid? How much are we given? Do you think it's a good idea? Can we do this? Can we substitute this? And it is sometimes a perception, but I wouldn't go as far as to say that it is wrong. No, but I think that it is actually based on the assessments of the clinicians. But fluids are actually prescribed for most inpatients. And if you remember the first slide I presented, the different reasons why we give fluids. One of them is simply to keep a patent line. We just don't need it. We don't need to give fluids to the patient, but we need his line to stay patent, just so that we do not have challenges of either administering drug or something like that. So it's really a broad spectrum as to why fluids are given. The important thing is that there is an ethical reason for giving them, and it is justifiable. Now, for the stability of fluids, yes, this is a very common observation for mannitol, because and sometimes even 50% dextrose water, you find them crystallizing out because of challenges of storage temperatures in our environment. And whether it is right that we use some method, either cooling it or putting it in hot water to see that it melts and then we use it, I wouldn't say that is right. It is ethical, but that means what we actually need to do is to have better storage systems for our hypertonic fluids. Because in some places they put the 10% or 20% mannitol inside hot water, and then it dissolves and then they use it. But I wouldn't say it is right. We perhaps should just work better on providing a better storage storage temperatures for those. So I don't know if there's a question. I think that is all that I got. I don't know if there's any that I didn't get.
If anyone have question, thank you very much for that response. Excuse me. Do we have any more questions? Comments, contribution?
Okay, I just noticed on the chat that there's a question that says, what is the role of community pharmacists in fluid stewardship? Okay. I think the community pharmacists actually, thank you for this question, have a huge role to play in the community because the way things are, you'll find that a lot of people stay at home and they're sick and somebody just decides to give them fluids. And they said, you know, I was so sick, and they even had to give me fluids. And I think it is a perception, and it is quite wrong. And I think that you actually, pharmacists in the community actually even have a better opportunity to do a fluid stewardship, meaning that if you're in the community and you're practicing and somebody is coming for fluids that he's not going to use in the hospital. And I think this is where you need to educate them as to who is using the fluid, why they're using the fluid, how much of it they're going to use. This is the different kind of fluids that they can use, and help whoever it is that is going to use that fluid to understand that it is simply not fluids, are not water, and for your patients to understand that fluids, when they come to buy, that it's just not water, and they need to know that there is actually a detrimental effect to using fluids, because they are actually drugs as much as they are not considered to be drugs. So I think you can actually hold like community presentations where you actually teach people that fluids are different. Fluids are actually drugs. They are as important as their antihypertensives and antidiabetics. And you can make it really impactful. And I think that would be a huge contribution to your community.
Thank you so much for that. I cite Professor Wanang.
Hello.
Let me just recognize a few people. Professor Wanang, thank you for coming on this call. I also see Pharmacist Cotton. Yeah, thank you so much, sir. I can see Pharmacist Cotton on the call too. Thank you, ma, for coming. Pharmacist Lara.
God bless you.
Yeah, thank you so much for taking out time. Yeah. Yes, we can go ahead. I can't call everyone, but I just appreciate everyone so that people can actually really say,
Yeah, Joe, please let me just add this.
Okay.
The presentation was very beautiful, and it's instructive that when a solution is turbid or crystals are formed, like the presenter said, the storage condition need to be checked. And I don't think it is proper or ethical for pharmacists to dispense that, so that it don't become a situation where you have to be, to answer questions as to a pharmacist dispense a drug that has expired or whatever. So if the infusion is turbid or its crystals has formed on it, that shows that there's a storage problem. So the pharmacist in charge should actually go ahead and upscale the storage facility. But such an infusion should not be dispensed at all.
Very much. Thank you very much for that contribution. I think there's one more question on the chat. Somebody's asking, can Ringer's lactate fluid be used in diabetic patients?
Yes. Now, every infusion will have its restrictions. However, it is a matter of what situation it is that you have at that time and what it is you can do to so to speak, I would not say manipulate, but to do a risk-benefit analysis of what you're doing. For example, the content of Ringer's that is usually controversial is the potassium, which affects insulin, calcium, and lactate. So these three are what usually make the use of Ringer's a bit difficult for clinicians to prescribe. And they would rather take the simpler route of let's just use normal saline, or we can add the potassium through another route, or I really don't know, I can't wait, I don't know what the serum potassium levels are. So the answer cannot be a classical yes, neither can it be a classical no. It depends on what it is that that particular patient presents with in terms of his EUCR, in terms of what it is exactly that is presenting, that the patient is presenting. You see, a diabetic, hypertensive, septic patient, are we in a situation where we do not have fluids? The only fluid we have is Ringer's. However, patient is hypokalemic, or what is the situation? So it's a bit hard to answer. There's no hard fast rule as to saying we cannot use Bringas lactate for a diabetic patient. No, it's not true. Because the only problem with diabetic patients is, as you know, is that usually because of their diabetes, they have a complex scenario that they present with. A lot of things are not where they're supposed to be, whether it's cardiac, whether it is the glucose, whether it is infection, whether it is they usually present in so many different ways, and so we have to look at it from that perspective.
Thank you very much for that response. Are there any more questions? Okay, in the absence of none, we'll have our closing prayers and vote of thanks. For closing prayers.
Vote of thanks first. Vote of thanks by Dr. Ola. Dr. Ola, can.
Okay, all right.
Okay, permit me to stand on any already established protocol. First of all, I want us to really go ahead and thank everybody that made it to this presentation this evening. You're all appreciated. I can't mention all your names, all our leaders, the senior colleagues, the fellows. We are all appreciated. Thank you for coming. And I also want to thank the moderator. Thank you very much for a wonderful work you've done this night. I also want to appreciate even the presenter. You've really done justice to this. And you told us to, carry forward worship in our respective practices, both the hospital, community, and wherever we find ourselves. So we just want to say a very big thank you to everybody that made it this night, and also thank Almighty God for making it possible for all of us to be here. So it's a very big thank you to us all. Thank you.
Okay, before we take the opening, the
Hello,
closing
can
prayer.
you hear me? I'm done.
Yes, before we take the closing prayer, I just want to say that we have a lineup of activities. So in the critical care unit, you have to get it right. It's either you are duplicating something, you're omitting something, or there are errors. So there is something we use to be able to get it right. The fast hug maidens. Right. So the F is what we have started with today. That's the fluid, but we also have the feeding aspect of it. So in our next presentation, we're going to have to talk about the feeding aspect of it. Somebody asked the question, "Oh, if you're feeding well, do you need to still have to take fluid?" That will be tackled better in the next presentation. And after that, the fast hug maiden, like I said, is an acronym. And so we'll go to, after we're done with A, we'll go to AS, TH, UG, and all that, straight down and all that. That's how our presentations are going to be. So we would employ everyone on this call to join us in the next presentation so that together, like I say, our service is to humanity. So we're trying to get ourselves together to see how we can network, we can gather knowledge together, and able to serve humanity better. So the next presentation we will still announce, and we're looking forward to seeing everyone on this call still come to get the knowledge so that we can take it to our various facilities and organizations and then be able to help our patients and our clients better. So basically that's what I just wanted to chip in before we take in the closing prayer. Thank you once again for coming on the call, and God bless you all.
Thank you very much, ma. For the closing prayer, can we have Pharmacist Abubakar Abdulkarim?
Dr. Budikisu, I see you. Thank you for coming on the call. I can't call every name. The pharmacist Shatang, I see you. I see everyone. God bless you all for coming.
Thank you. It's Pharmacist Abubakar Abdulkarim close to his phone.
If it's not, Dr. Budikisu, can you take it for us, please? Dr. Amuda, are you there?
Okay, thank you very much. We thank God Almighty for making it possible to come to the end of today's lecture. Let me say lecture because it was very, very great. We thank God Almighty and we beseech Him, may He continue to increase us in faith. May He continue to increase us in knowledge. Thank you, everyone. Thank you.
Thank you very much, ma'am. So without further ado,
thank you.
Thank you very much, ma'am. So wish everyone a wonderful night. Thank you for coming for today's presentation. And we hope to see you again next time for another enlightening presentation. Thank you so much. Thank you for coming.
Thank you.
Thank you all.
Thank you.
everyone.
Good night. Thank everyone. Good night. Thank everyone for coming. Thank you. Thank you. Thank you, everyone. Thank you.
Have a wonderful evening.
Have a good night. Rest, everyone. I appreciate your coming. Thank you. God bless you all.
Ma, you'll have done giveaway for us now.
I should have done what?
Giveaway.
That's true. Oh, that's true. That will happen in our next presentation. Thank you for wonderful moderation, Dr. Laila. God bless you. Thank you so much.
Thank you very much. Good night.